Hello. So this is the first episode of our new podcast, SBG New Braunfels podcast. SBG New Braunfels is a Brazilian Jiu-Jitsu school. We teach self-defense, Brazilian Jiu-Jitsu. We now have kickboxing. We have an amazing kids program. And we just consider ourselves a part of the New Braunfels community, so we like to interview different members, sometimes people just in the community, get people to know what is available for them in the New Braunfels area and everything. I'm here today with Rob Rakowczyk. I have a hard time with his name, as you can tell, Rakowczyk. Rob's a doctor, and he has taken on, how do you best describe it? What's the best term here?
So the business model name is called a direct primary care clinic. And so essentially the idea is taking insurance out of your primary care. So I'm a family medicine physician. I worked for a couple years in a normal fee for service clinic, which is where you go in, they're gonna do a visit with you, and then they bill insurance for that visit. And I got out of that for various reasons we can kind of jump into. But in this kind of model, we take insurance out of the equation. So patients pay a single monthly membership fee, and that covers all my professional services.
Okay, cool. And what have you seen has been like the biggest benefit for patients?
So there's several. Convenience is one of the big ones. So when we strip out insurance as being the way that my services get reimbursed, that means I don't have to do any of the things that are part of their checklist for what counts as a billable visit. So that means when you come in for a visit with me, it's a much faster situation, and a lot of times we can address things just over text message or quick phone call, which is very difficult to get done at other kind of busy insurance-based clinic. So the convenience in that way, and then we also make sure to maintain appointments that are either same day or next day for kind of more urgent concerns. And then the amount of time that we get to spend during individual visits allows you to either kind of consolidate more questions to get it addressed in one time, or we dig a little deeper into what's going on. So I was frequently finding myself, if you just spend a few more minutes talking to somebody about their symptoms, that would drastically change the diagnosis.
I see.
But because we had such limited time in the other kind of business model, there's an incentive to just kind of address the thing that is what you're first coming up with as the diagnosis and treat that. And then if that's not working, come back in 3 months and we'll try again.
I see. So when you were working in like a hospital proper, it's like, I know the experience of just being a patient in those situations. Just feel like a doctor will see you like in a minute. He comes in, okay, yeah, how are you feeling? Is your knee okay? Okay, goodbye. Like kind of, they're in and out pretty quick.
Right.
Like,
there's a lot of pressure to get through.
He's got a lot to get through, I'm sure. Yeah.
And what I didn't really realize until I got out of that world is how much of that is driven by the fact that insurance is the payer. And when you have that kind of a setup, that means, well, now you have to have a lot of staff to handle all the different kind of insurance claims that are happening, being rejected, resubmitting them, making sure you're meeting all their quality metrics that may or may not have anything to do with the person sitting in front of you.
I see.
So now you've got all this extra staff, which means there's an extra cost to just keeping the doors open.
Sure.
That means you have to have a higher patient volume that you're seeing every day.
The patient's got to pay more for all that too, right? I would think.
So I wouldn't say that there's like a higher cost to the patients in terms of like they're direct. They wouldn't see it directly.
Okay.
The cost comes in terms of like you don't get as much time now with the doctor.
Sure.
Because they have to see so many patients to keep the doors open now.
I see.
So I don't have to have. I mean, when I was at my previous clinic, there was, let's say, about 9 or 10 staff members between the nurses, front desk, and back office, and 2 doctors.
I see.
And so I don't have any staff. I kind of wear all the hats in the clinic. And so that translates to I don't have to see 20, 30 patients a day.
I see. You can
To
just
cover
give
all the
more
costs.
like deep care for each person, kind of.
Yeah.
That's awesome.
So it's been fun because we get to do a lot more with the patients in terms of figuring out how to optimize whatever health conditions they've got. Patients that aren't particularly sick or complicated, we get to spend more time talking about, well, there's all these other kinds of screenings that can be done now, whereas you may have been locked into, well, these are the things that insurance covers. Since I've stepped outside of that, now I'm looking at, well, what are the things that we can do on a cash pay basis? And it turns out there's quite a bit that's not wildly expensive.
I see.
So
give me some examples of that. Like...
So one of the things that I've been kind of dipping my toes in is just some more advanced testing for different subtypes of cholesterol, and trying to get a better sense of someone's risk of developing cardiovascular disease.
I see.
You can do that much earlier in life. There's kind of screening guidelines that are set up at a national level by a group called the U.S. Preventive Services Task Force. And the way they generate these guidelines, they're looking at kind of years of life saved if we screen for this, say cancer or heart disease, compared to what's the cost of the screening. And then whenever they say, like, this is a recommended thing, well, now that becomes something that insurance has to cover as a preventive screening.
I see.
Well, if you don't have to worry about what insurance may or may not cover, then you can start to look at, okay, well, setting aside the population level screening recommendations, what makes sense for the person sitting in front of me?
I see.
And so there's, depending on someone's preferences, there's much more screenings that can be done.
You got me intrigued now because I always feel like I'm always hearing something different about cholesterol. Like it's like either the big baddie or somebody like it's not bad at all, or like it's like, and then I as you know, I'm friends with Rob Wolf, and he'll be like, well, no, it can be bad, but it's more nuanced than that. Like, and he usually recommends I do some sort of blood work if I talk about something. It's like, well, and I don't. It's just not my foray. So it's like, is it LDLs, is it HDLs, is it the triglycerides or whatever?
Right. And it gets complicated, and there's very little time to have those kinds of conversations in a very fast-paced clinic. And there's a bunch of different ways to kind of slice that up and look at it. So yeah, that's kind of another thing that I've enjoyed doing is I get a lot more time to provide patient education. So my patients get to be more knowledgeable about the medications that we're prescribing, why are we taking them, what to expect with them.
That's cool.
And if there's a problem with them, they can reach out to me directly. They have a number that rings right to my phone, or text messaging on like an encrypted app. So, yeah.
Cool. Any other big things that come to mind, like that you have been very, like similarly exciting to you, like being able to work with patients more directly and stuff?
I've been able to do home visits. So that was something that I had imagined I was going to be able to do in medical school, and I actually got a doctor bag when I graduated from my brothers and sisters.
I see.
And when I opened this clinic, that was the first time I was able to actually utilize that as part of some home visits. So that was kind of cool.
Yeah. How did that, and why do you do a home visit? And tell me more about that a little.
So Those have been for some of the sickest patients. So there was a lady that was paralyzed from a stroke, and they couldn't get her out of the house to go see a doctor to get medications to manage the ongoing issues. And so that was a very gratifying thing to be able to provide that service for them. And other situations, had a patient who was on hospice and was very, very difficult to leave the house. So somebody else was very sick and didn't want to leave the house, which was just very dehydrated and everything, and was able to go to the house. And I don't normally draw my own labs, but I'm able to. So we were able to go to her house and draw some labs, make sure she was done okay.
Okay. So you usually have people go somewhere else to get the labs done?
Yeah, so there's a lab company that I work with in town, and have kind of set up rates that one of the things I offer to my patients is we can do what's called client billing, which is kind of a third option for paying for labs. Normally you'd either bill insurance, the patient just pays cash, or what's not usually offered at a clinic is what's called client billing, where they send me the bill from the lab the month after all my patients have had their lab drawn, and then I would take that invoice, and some direct primary care clinics, they just cover the cost themselves, and for myself, I send those charges along to the patients, and that way, I set it up that way just to avoid any kind of possible conflict of interest where it's like, it's going to cost me money if we order this, so I don't want to.
I see.
I wanted to limit that. Just this is what it's going to cost, and then pass it along to them.
Gotcha.
But the rates we're getting are incredibly cheap, way cheaper than what you would pay as a cash patient to the lab even.
I see. Okay, awesome. Cool.
So there's a lot of patients that have insurance that still opt for that, even though their labs may be covered by insurance. Sometimes there's like a deductible that has to be met, and so they pay full price for those labs anyways. Sometimes there's a situation though of insurance would say this lab was not medically necessary based on our standards, so we're not going to cover that. And now a lab that would have cost me less than $10, they have to pay $150 because it was billed to insurance but rejected.
I see. Gotcha. I see. Yeah, well, it's such a complicated world. So it's so yeah. I mean, anything else you'd like to say about the subject, or?
I think we've kind of covered all the main points, but I guess the thing that I'm really enjoying about it is I feel like I am getting to know my patients much better, and so that's really like a neat part of it.
Sure. Sense of actually knowing who they are, what they're, and I'm sure my feeling on things is everybody's pretty unique, right? Like I give advice on diet, for example, because I'm a gym owner and stuff, and I do take quite a bit from Rob Wolf, my friend, and it's like, try a few things, because I personally thrive pretty well on a very low carb diet. I feel much better, I perform a lot better, I just feel clear, but that might not work that way for some people. It may not feel that good, I don't think it's I think there are certain relatively universal traits of diet that would be helpful, like don't consume 7,000 calories a day, especially if you're not super busy, but at the same time, as far as what to eat, I think protein good, but I think protein high and then dialing fat and carbs to what I actually think the dialing of the fat and the carbs is very individual, and generally speaking, how you dial that, if you're dialing it successfully, it's probably the successful would be that it brings your calories down in general. And if you're not dialing it successfully, it's probably driving your calories up. Does that make sense? So carbs aren't bad by themselves, but like they have a nasty tendency to make people overeat. You're like, oh,
Right.
and you
Right.
keep just smashing this because your body doesn't have much of a shutoff valve for that. But it's just very individual, right? Like some people don't have that problem exactly, so it's like them having some mashed potatoes isn't going to make a big difference, right? Other guys eat mashed potatoes, which leads to ice cream, which leads to the other things. That's
Right.
me. As soon as I have carbs again, I'm just like, oh my god, like give it
So
all to me. Like my body just goes nuts. Like it's just, and then I'll overeat, like way overeat. So I fly way past the mark. So
Yeah.
but so individual need, I think, is probably huge. But.
Yeah, and regarding what you were just talking about, that is kind of a common conversation I have with people where some people do have like a personality or tendency to eat one way. Other people, it's like, no, if I can't have that stuff, I'm just going to be thinking about it all the time. But I do really well if I just have a little bit. And so there's a lot of exploration too for individual people of like what works for you individually.
Sure. Well, cool, man. Well, hey, it was great to sit down and talk with you. Thanks for coming on the show and like.
Thanks so much for having me.
Yeah, sure.